I don't know. I don't know where Dr. Yagutis is. Okay, so it's a big topic. We're talking about instability of the shoulder, which will take us a few lectures. So instability can be divided into macro instability, where you have really gross instability of the shoulder, and that primarily involves injuries to the glenohumeral ligaments, the labrum, the capsule, and bone injuries. And then you can have micro instability, which is typically injuries of the superior structures, and this has become more and more kind of controversial in recent years. So if we look at the anatomy, you're all familiar with the anatomy. Here's the glenoid. The anterior labrum attaches along the anterior portion of the labrum. The capsule anteriorly folds on itself, and a portion of it, called the middle glenohumeral ligament, attaches to more along the anterior neck of the glenoid, underneath the subscapularis tendon in this area. And then, so it looks like we, hi Jeff.
Hi.
Welcome. We're just talking about shoulder instability.
Okay.
And then if we do kind of an axial plane through the shoulder, you're all familiar with this, subscapularis muscle and tendon. Here's the anterior capsule, which in through here is the middle glenohumeral ligament, the anterior labrum, the posterior labrum, and the posterior capsule, which we see typically, and this is typically what you're used to seeing. So here's the subscapularis muscle and the tendon attaching to the lesser tuberosity. The middle glenohumeral ligament is this black structure between the muscle belly and the anterior labrum. The anterior labrum, posterior labrum, and here's the posterior capsule back in this area. Now, if we look anteriorly and superiorly, there is some complex anatomy that we kind of need to go through. So here's an axial image through the superior portion of the glenohumeral joint space. There's the anterior labrum. Here's the superior glenohumeral ligament up in this area. If we go to the sagittal plane, what we can see is a number of structures coming off from here. So the rotator cuff interval is this space between the anterior margin of the supraspinatus muscle and the superior margin of the subscapularis muscle. And this allows an opening for the coracoid process to come out, where the short head of the biceps attaches. So this is the rotator cuff interval that you're all familiar with. In here, there are a number of different structures which are important. Now in the sagittal plane, so here we actually have the superior labrum, which you can see on the axial image here, on the sagittal image there. And then there's the middle glenohumeral ligament. Now the middle glenohumeral ligament will come off here and will extend inferiorly and anteriorly. And so this would be a cut right up at the top here, where we're just catching the middle glenohumeral ligament where it originates here on the glenoid side. And then further up here we have the superior glenohumeral ligament up in this area, and we can see some kind of stranding other ligaments that also are not so common. They're very variable in the area of the rotator cuff interval. So up in this area, anatomic variants are very common. We'll talk about a labral recess, and there's a lot of debate about how frequent these are, whether they're even normal or not. Sublabral foramen, which typically is said to be around 20%. A Buford complex, which some people say is 6.5%, but other people have said as low as 2%. And then the superior insertion of the inferior glenohumeral ligament. And I don't know the percentage of this. See it fairly commonly. I would guess it's in the same vicinity of around 10%, but we'll talk about, and there's some others that are less well defined. So superiorly, we can have a labral recess, and this is when you see fluid between the labrum and the glenoid. Okay, thank you. Funny, I sent it to him. Okay, hopefully John will join us. So it's variable. So a recess is where you have a potential space between the labrum and the glenoid. And if you have fluid in the joint space, especially if you have contrast, then you'll see the fluid or the contrast extending below the labrum, between the labrum and the bone. And this is not present in children. And hey, John, thanks for joining.
For some reason, my iPad didn't receive the message.
That's funny because I know that it was on it. But anyway, well, good. I'm glad you joined us.
The phone got it, and then after I got the second link, the first link came on.
Oh, is that right? Okay. Oh, good. Thanks for joining us.
So, modern technology.
Right. We're talking about shoulder instability.
Ah, good. I think I know something about it. I don't know.
I think so.
I'll listen to you, John.
Okay, now I'm just talking about some of the normal variants in the superior part of the glenohumeral joint space.
Oh, great.
Okay. So this potential space between the labrum and the glenoid is not seen in young kids. You typically start seeing it in the teenage years, and the older the individuals are, the more common it is. So many people believe that it's kind of an acquired anatomic change, probably kind of from wear and tear, but it's generally believed to not be pathologic. But you should not see it below the midline. If you see it below the midline, you're much more likely talking about an actual tear with instability. So what does it look like? Here we can see an oblique coronal image. This patient actually has a little bit of metal artifact here. But here we can see fluid between the articular cartilages of the glenohumeral joint space, and this fluid extends up deep to the superior labrum here, and that's a recess. Let's go. I guess that's calcium. Okay, and here we go. Here's a T2 weighted image where we can again see this fluid superficial to the articular cartilage, going between the articular cartilage and the superior labrum. And on the PD fat-sat image, we can see it even better here between the labrum and the articular cartilage. So this would be a superior recess, and this is generally considered a normal variant. And one of the things you see are that the margins are nice and smooth. You don't have any signal going into the labrum itself. And sometimes this can go superiorly all the way up here to the bone. And that's a superior recess as long as the margins are smooth. Now, here's a patient who has a 4-year history of shoulder pain. And what we see here is a superior labrum. Here we can see the articular cartilage is intact, and we can see this fluid going deep between the superior labrum and the articular cartilage. And notice how smooth all the surfaces are. So there are a lot of people who were concerned that if it got too large here, it would be abnormal. And there are several studies now that have looked at size here, and generally the thickness of the superior recess does not really correlate with whether it's pathologic or not, or whether it's considered pathologic at arthroscopy. It's really whether the signal goes into the labrum or not. So this is another normal superior recess. And on the axial images, we can see it nicely here. And again, if it's a tear, you'll see a regularity of the margins and fluid going into the actual labrum itself. So that's another superior recess. Okay, so Jeff, what do you think of this case?
All right, so the coronal looks like PD fat-sat images, probably after arthrogram.
Yeah, this is an arthrogram with T1 fat-sat images. Yep.
T1. So as we were discussing earlier, we do see fluid that's superficial to the articular cartilage, and however, the margins are irregular, involving the superior labrum. So this is a
looks smooth here.
Looks like
looks like it may be irregular there. I agree.
Yeah, so the regular there.
The axial images.
And the axial images demonstrate that again, we're seeing irregularity of the labrum, anterior labrum, probably, as well as it looks like the fluid is going across the entire labrum. So I think this is essentially a tear of the anterior inferior labrum.
Well, I think it's a little bit tough on the coronals, but I agree with you. I think the irregularity here is highly suspicious that it's a tear. This looks like it could just be a normal recess. If we go to the axial images, however, well, we can see this really looks irregular. And here we clearly see that this abnormality is actually going into the substance of the anterior-superior labrum, which we see there. And then we're inferior to it on this particular cut, and this was a superior labral tear. And that's because you can clearly see that the signal is actually going into the labrum itself. Here's the articular cartilage back here. That's going to be labrum, this dark area there. That's the tear, and then there's labrum again here. So if you see the signal going clearly into labrum in any location, then it's a tear. Okay. So, John, what do you think of this one?
Okay, so here we have a 52-year-old male with increasing pain for 9 months. We're evaluating for impingement. So, well, in addition to some rotator cuff issues, which we won't get into, we are seeing a little bit of linear signal within the superior labrum. It could just be the cut here. It doesn't necessarily look, I mean, it looks a little irregular, but it's not really extending.
There's a little bit of increased signal, but it's not a great image. This was on 6/18/05.
Okay.
There is a little bit of signal there. This is on 12/20/07.
Okay.
Where he's 3 years older, but now he has persistent pain.
Okay. Well, you know, on this image, it looks a lot smoother. I mean,
so this is now an arthrogram, and the other one was not an arthrogram.
Okay, so we've got our contrast sort of extending into what I think is going to work out to be a recess.
Okay.
Not necessarily a tear.
Okay, so and here we can see it going across here. But I agree with you. There's no signal actually going into the labrum. See, the biceps anchor is intact.
Mm-hmm.
And they're actually, okay. So this was called a superior labral tear. And then this is a follow-up study. What is this, a year later? Let me see. About 9 months later. And so what do you see here?
Okay, well, I guess we see, we still see that nice, smooth, linear signal extending kind of under it, but not really into the labrum itself.
Yeah. Here's the neck cut up.
Yeah, so we've got some instrumentation, interval, of course, but
so
I want to sit down on this one.
Okay, so he had surgery here. So he had a slap repair, and this is the anchor for the tap repair, but his symptoms didn't change after this. And so this was actually a surgical repair of a superior recess. And one of the reasons why surgery for the slap is a lot less common now than it was, say, 10 years ago, is because more and more data found out that often if you do repairs of these recesses, you can actually over-constrain the shoulder, and sometimes they can become more symptomatic. So when you see nice smooth margins like this, I suggest you call it a recess rather than a tear. And this is someone who did not get better with the surgery. John, do you want to comment?
It's not recommended to do surgery in this age group for labral tears in this area of the biceps anchor area. Maybe some debridement would be the trick. And if you really suspect a tear, you may want to do a tenodesis of the biceps rather than what it did. It doesn't look like the labrum was reattached. I mean, the biceps. And is that a cyst that I'm looking at?
Over here?
Yes.
Yeah. I don't remember exactly what that was. Back and look at it.
There, wasn't it?
Certainly, if you had a paralabral cyst, that would suggest a tear.
Yeah.
I forgot the details here. I think when all was said and done in this particular case, we did not believe this was a tear, and even when another surgeon went back and looked at the arthroscopic findings, everything was nice and smooth, and this was thought to be a superior recess.
Yeah, I don't think this age group should have any kind of surgery of this kind. Maybe debridement if there's any irregularity, but
there wasn't much irregularity there.
But definitely not a repair.
Okay.
Dr. Pierce?
Yes.
When you talk about the superior recess, so let's say the 12 to 3 goes from the most superior aspect of the labrum to the 3 o'clock anterior position. Mm-hmm. This also applies from the other direction, right? Involving the posterior aspect of the superior. Mm-hmm. Okay. So just as long as it doesn't go below the level of the equator.
Yeah.
Okay.
Okay. Okay. Deshali, do you think what do you think's going on here?
So, axial T1 weighted image in a patient who's had a arthrogram, and this low signal intensity structure adjacent to the anterior glenoid, maybe a ligament, like a middle glenohumeral ligament, in the labrum more anteriorly.
It's a little tiny bit irregular, but there's the labrum midline. Now here, this is now a cut, the same patient, but this is a cut below the midline.
And then so there's this low signal intensity structure that's bowing. It attaches to the humerus, and then it comes and bows in. It comes more proximally towards the inner aspect of the glenohumeral joint. So
you're talking about this?
Yeah.
Okay.
So this person's not extremely internally rotated, but maybe again ligament coming in.
So what about this fluid deep to the labrum?
There is a little bit of fluid deep to the labrum, and because it's below the level of the midline, we can say that, yeah, so there could be a labral tear.
So this was a labral injury. There was also a partial tear of the middle glenohumeral ligament in this patient. Okay. So here's the case. Here's an axial image, and if we look anteriorly, we can kind of see 3 structures here. So this is clearly the articular cartilage coming around here. This must be the labrum, and this is another structure, but this is deep to the subscapularis. So if we look at this, here we have a fluid in between the labrum and the articular cartilage, and that's a sublabral foramen. And this structure here is the middle glenohumeral ligament, which you can always determine. You can follow it down. Now, sometimes you can have a tear of the anterior labrum, and it can look like a middle glenohumeral ligament, but when you follow it down, the middle glenohumeral ligament fuses with the deep portion of the subscapularis tendon, whereas the labrum will come back and fuse to the labrum. So you can follow it to determine what the structures are. So that's middle glenohumeral ligament, labrum, and bone, and we have a sublabral foramen. This is anterior-superiorly, and this is a potential space here deep to the labrum and the bone anteriorly and superiorly, which we call a sublabral foramen. And these sometimes can be very prominent. Here are a couple of images in the same patient. This shows the biceps tendon coming across superior glenohumeral ligament here. If we go down a cut, we can see this is the origin from the glenoid of the middle glenohumeral ligament there. If we come down here, all of a sudden now we have what looks like maybe a displaced labrum, but if you follow it, it goes down and actually fuses to the deep surface of the subscapularis tendon. If you go to the oblique coronal images, we can see this is really a cord-like middle glenohumeral ligament coming down here. And here on the sagittal images, you can see that this is the middle glenohumeral ligament coming down and fusing to the subscapularis tendon. So, Max, what do you think this is? What kind of anatomy would we call that?
Well, I mean, the middle glenohumeral ligament connecting to the subscapularis, you mean, or why it's thickened?
But where's the labrum?
Well, it's absent. There's fluid between the labrum and the bone, so I would presume there's a fracture of the anterior labrum. Well, actually, no. This is a variant, Buford complex. Yeah.
So this is called the Buford complex. I believe Buford was a ortho fellow at UCLA and did some cadaver studies, and he found that. Is that right, John?
As far as I know, but what's interesting is Campbell's quotes Snyder, Steve Snyder, and says, as Snyder explains his slap tears, he says Campbell says so-called Buford complex described by Snyder.
Oh, really?
So that confused me. And then I looked up the bibliography at Campbell's, and they don't mention Buford, but they do mention him in a text.
Okay. All right.
And maybe Snyder did, well.
So Snyder might have been involved in the research with him.
Well, maybe, and sometimes there's politics involved.
Oh, not in medicine. There's no politics in medicine.
Oh yeah. I'm sure you know better than that, yeah.
Well, if I talk to Steve again, I'll ask him. That's intriguing. Okay.
They quote Snyder, and he says so-called Buford complex. I looked at that. I took a double take.
Well, I talk to Steve Snyder every so often, so next time I talk to him, I'll ask him.
All right.
Okay. So what we have is absence of the anterior-superior labrum and a thickened cord-like middle glenohumeral ligament, and this is considered a normal variant, and it's still stable. The thickened middle glenohumeral ligament takes over for the stability aspects of the anterior-superior labrum, and if you go far enough down, you'll start seeing a normal anterior labrum more inferiorly. But just be aware of this complex and don't call an anterior-superior labral tear with this kind of anatomy. And that's why it's important when you see this, you have to determine whether this black structure here in the anterior part of the joint space is that middle glenohumeral ligament or is it labrum. That makes a big difference. And so what you have to do is follow it down and to see if it fuses with the subscapularis tendon. And then you can also see on the other images how, in this case, it comes down and fuses with the subscapularis tendon. And therefore, this is a cord-like middle glenohumeral ligament and no labrum, so it's a Buford complex.
Superiorly, Snyder described the superior glenohumeral ligament attaches to the biceps tendon.
Okay. Well, actually, let me go back. So here's the biceps tendon here. That's the middle glenohumeral ligament. And they really come out, they really kind of attach to the bone in a similar location here.
That's superior, isn't it, John? That's superior ligament.
Yeah, so, this is the origin of we talked about earlier. At this location, three things come out. The long head of the biceps tendon attaches here. The middle glenohumeral ligament originates here and goes inferiorly right through here. And the other thing that attaches here is the superior glenohumeral ligament. So all three of those things, and if we come back here, we had a diagram of that earlier. Where did I have that? Somewhere here. Yeah, here's an example where we can see that. So here would be the origin of the biceps tendon right there, or the insertion of the biceps tendon on the superior glenoid. There's the middle glenohumeral ligament, and that's the superior glenohumeral ligament. So they all really come out of that same location. And so, yeah, just like you said, they have kind of a common origin there from the bone.
Right, and then they leave a space.
Yeah. Okay, so this is the
a bare space.
Okay, great. So Jeff, what do you think of this case?
28-year-old female, 8 months post a labral repair. So it looks like we have another arthrogram. And the axial image, I've seen that the I'm at the level of the subscapularis tendon, and so looking at the labrum, the anterior labrum, I'd say it doesn't have a truly triangular morphology. I mean, it appears to be like a tail.
So it's a little irregular here. I agree with you.
Yeah, a little regular.
The next cut here, we see it looks like this. The next cut going up, it looks like this. So what do you think of the labrum now?
Well, post-labral repair, correlate with surgery, but I mean, it appears that the labrum, it looks like that there is a small, very thin, hyperintense line heading through it.
So this is articular cartilage here, and I don't really see a labrum there.
Okay.
That's the glenohumeral ligament over here.
Yeah, I mean, this could represent, a Buford complex.
Okay. So let's go back here. Sorry, So this is the middle glenohumeral ligament attaching to the subscapularis tendon. Go one cut up, we have this appearance, and here we have no anterior-superior labrum, and here we have now a better formed middle glenohumeral ligament. So this looks like a like middle glenohumeral ligament. So this really looks like a Buford complex, right?
Yes.
And then here what we have is a suture anchor from the repair, and here's the irregularity of the repair site. This is the middle glenohumeral ligament coming around here. So this was actually a repair of the middle glenohumeral ligament in someone who had a Buford complex.
So they repaired a normal variant? Is that what they did?
Yeah, so they repaired a normal variant.
So that would cause problems.
Oh, I see.
Let's see, so here's a superior reset, let's see. And this is the middle glenohumeral ligament that's coming up there, and here's where the suture anchor was placed. There's the suture anchor. So this is just to point out that it's important to know these anatomic variants and describe them appropriately in the report. Otherwise, the wrong surgery can be performed, because if you call it a tear, then depending upon the orthopedic surgeon, they might very well go in and try to do a repair. And if it's a normal variant, you don't want that to happen.
They can't tell on surgery difference between a middle glenohumeral ligament and anterior labrum.
John, can you answer that?
Pardon me?
The question is, we've seen two cases where, because the radiology report said that there was a superior labral tear, the surgeons went in and did repairs on normal variants. And the question was, how difficult is it to differentiate normal variants from actual labral tears at arthroscopy?
Well, everything is smooth at arthroscopy, so it doesn't look like a tear. There's no fraying, there's no sharp edges, and so on. One has to remember that the capsule around the shoulder joint is very loose and quite thin, and the ligaments are the only things that you actually see on MRI and they're basically a thickening of the capsule for the most part. Now, in some people you can see them quite well, and some people all you see is just a thickened capsule, and at the glenoid area, the ligaments are very broad. So and then when you have the Buford complex, they just look like a part of the capsule thickened, and you don't see the labrum, and it imitates the labrum, as you see here on the arrow on the right. So they're operated on the wrong area. It seems to me.
Yeah. So I think the situation is, this was at a time when slap repairs were really popular, and that people have kind of backed off a little bit since then. But I think the bottom line still is, mistakes can be made at medicine, and it's best to start out with a report that doesn't have a mistake in it, and then you're less likely to have a mistake in the care of the patient.
That's for sure. But when you look at it, something that looks very, very not ragged, very smooth, and everything is very rounded off, and especially if the patient is 20 years old, you have to think about everything is okay. You better look for some other pathology, maybe just a sore shoulder from overactivity.
Okay.
It's a baseball player, so you expect sore shoulders.
Right. Jonah, what do you think of this case?
All right, so here we have a 20-year-old baseball player with shoulder pain. We're evaluating for a labral tear. Now, the first thing that's catching my eye on this case is this kind of edematous structure with some fluid signal abnormality, kind of a little bit adjacent to the humeral head. Yeah, you're outlining it there. Yeah, now if I'm looking at the labrum, I would argue that there is a little bit of a labrum that's intact there. So
this looks like articular cartilage, I think, here. I don't think we really see much of a labrum there. So the question is, what is this structure?
Well, this certainly could be, and I want to, of course, scroll through, but it does seem to be going to the subscap. So my first thought is that this is a torn MGHL.
Yeah. So you can get tears of the middle glenohumeral ligament. If you have a Buford complex, since it actually is a bigger structure and probably more important for stability, and with a Buford type complex, then you can get tears of the middle glenohumeral ligament. And I think that's what it is.
John, it depends in what position the arm is.
Yep.
The superior one gets torn with the arm at the side, and the elbow gets pushed upward. That's the superior glenohumeral ligament prevents superior migration of the humerus. And the middle is when the arm is abducted 45 degrees and external rotation is attempted. That's when it gets tight. And then the inferior glenohumeral ligament is when you abduct the arm to 90 degrees and externally rotate. That's when the subluxus and that ligament is torn. So that's when the ligaments become tight, is in those different motions.
Good. Thanks, John. And here we can see going more inferiorly along the cord-like middle glenohumeral ligament. Again, we see high signal intensity, and we can follow it all the way down here with the abnormal signal intensity within it until it actually inserts into the subscapularis. And there's the increased signal intensity on the sagittal images, and we can see that it's all part of the middle glenohumeral ligament coming down and fusing with the subscapularis tendon. So this was a tear of the middle glenohumeral ligament in a patient with a Buford complex. Okay, Deshali, what do you think of this one?
Pain after falling injury and catching himself while falling. So you have axial and sagittal PD fat saturated images, and then there's on the axial image there's intermediate to high signal intensity within the in a location anterior to the glenoid, and I don't see a distinct low signal intensity labrum, so that may represent labral tissue anteriorly. And then on the sagittal image, yeah, outlining it, and then there's linear signal intensity, like a linear low signal intensity band that looks like it's connected to it. So, like, to follow it throughout its entirety, could this be the labrum that's detached versus the ligament that's detached?
It looks like it's surgery. This is all.
So it's labral tissue.
This is a isolated tear. If we go back here, it's not labrum. If you see here, this comes and attaches and fuses with the subscapularis tendon. The labrum is over here. This is the labrum. So this is someone who actually had another Buford complex with a cord-like middle glenohumeral ligament. In this case, a really complete tear of the middle glenohumeral ligament, which is now distally retracted and cordoned up here. So this is a middle glenohumeral ligament tear. And
as you can see, it's very broad, and then right after it goes to to the midline of the glenoid, then it really fans out from 2 o'clock down, from 2 or 3 o'clock down to the middle of the glenoid, and then after that, the inferior glenoid humeral ligament comes in. So you can actually get both of them torn. They're very close together on the glenoid at the origin. They separate when you go to the humeral side, when they attach to the humerus. That's when they become as individual ligaments that you can actually identify much easier than you're kind of what you're looking at there. You really can't be sure if it's middle or middle and inferior.
Yep. So that's a tear of the middle glenohumeral ligament.
Are there any other instances where the middle glenohumeral ligament would be thick, but not be a Buford complex, like the anterior labrum still there, and you have a thickened?
Yeah, you can have that too. That's less common, and sometimes it may be due to prior injury that's healed, but sometimes there's a lot of variation. Sometimes you can have both a thickened middle glenohumeral ligament and an anterior superior labrum. That's pretty uncommon. So, Max, what do you think of this case?
So we have one axial arthrogram T2. Is that T2? I can't tell if it's T2 or T1. That's T2, right? TD facet. Okay. PD facet. And we have a thickened low density structure in the anterior labrum. Small amount of signal intensity seen deep to that. So this could be, do you have any other sequences? Okay, so
here's some more sequences.
So we have an additional thickened, so we have a thickened middle glenohumeral ligament that is anterior to this thick anterior labrum. There's the anterior labrum, and then we have a dark signal structure, and that looks thick to me.
So what is this?
So that must be a torn anterior labrum.
Well, no, wait a second. So this is actually the anterior labrum. Nice and pointed.
Oh, okay. I was looking at that little dark structure.
Middle glenohumeral ligament.
Okay.
And how do you know it's middle glenohumeral ligament?
It's going to go to the subscapularis.
All the way down there, and it fuses to the subscapularis.
Okay.
This is the labrum coming down through here. So this is not a labral tear.
No, it's not. Yeah.
This is really kind of a normal variant. And here's where you have a thickened middle glenohumeral ligament and an anterior superior labrum. So when you have the labrum intact, which is the variant you were talking about before, it can occasionally look like a labral tear. But so you just need to follow the different components and make sure you know what you're looking at. So this turns out to not be a tear.
It's like everything else. No shoulder is the same.
Yeah. So this is just a cord-like middle glenohumeral ligament and not a Buford complex. Okay. And then we already talked about the sagittal plane here, middle glenohumeral ligament, and in the axial plane, you can see something. Oh, you can see that now. Okay. So, Jeff, what do you think of this case?
Question of labral tear on a college player. And so on this, let's get PD facet arthrogram. And okay, so again, we're at the level of the subscapularis tendon. And so I see the MGHL. I see what it, let's see here. This is a little bit tricky. So I think on this struct, what I'm most concerned about is that the anterior labrum appears to be so the anterior aspect of the labrum appears to be somewhat irregular, but there looks a bit irregular there. There's a secondary structure that's more medial, more proximal to that. Now, this is not what I would typically describe as a tear of the anterior labrum. So I'm thinking this must be a variant. This must be a variant. I just don't, because I look at the cartilage and it articulates with the anterior labrum.
Okay. So this was actually called an anterior labral tear, and because of that, this person was possibly not going to be drafted. Okay, but now this is probably the kind of a thickened middle glenohumeral ligament because he's a football player. So we've got to figure out what this is, and this is obviously the labrum. But the question is, what is this? If it's part of the labrum, then this has got to be a tear, though it's a very funny plane for a tear of the labrum. So that should be very suspicious right away. That's not the typical plane that you get labral tears in. So let's look at that. So now let's go down below, and if we look inferiorly and go up, we haven't talked about this structure. This is the
anterior band.
Inferior glenohumeral ligament or inferior band here, which is a thickening and a fold in the capsule, which is called the inferior glenohumeral ligament. And if we follow that up here, we can see that this structure here is actually contiguous.
High attachment.
Yeah, good. So
high attachment of the inferior glenohumeral ligament.
So this is actually a superior attachment of the inferior glenohumeral ligament. There's the inferior glenohumeral ligament. When we get up here, this is actually a superior attachment of the inferior glenohumeral ligament, which John was talking about a minute or two ago. And this is the labrum, and that's the middle glenohumeral ligament. And the attachment side of the inferior glenohumeral ligament is very variable. When it's very high, you can get a cleft between the labrum and the inferior glenohumeral ligament that can be misinterpreted as a tear, and that's what this is. So we saw this. He was being considered for arthroscopic surgery. When we saw this, we thought it was just a normal variant. So he basically went back. Letters were sent to all the NFL teams, and he was, I think, drafted third.
So the anterior labrum, it still looks like it doesn't have a sharp border on the anterior side.
Here it's sharp.
There it looks sharp, but so would you say anything? Would you say it's normal, or would you say it's degenerative?
I'd say it's a little bit irregular. But I tell you, athletes don't have normal labrum. And the problem is if you overcall injuries in athletes, it can really affect their career and not be significant. So it's another thing where I really prefer to undercall things. In fact, it's generally better to miss a lesion than overcall a lesion. Though the most radiologists really try to overcall things and not miss anything. There are a few things that are really bad to miss, but actually there are a lot of things in the joints where it's a much bigger problem if you overcall it and lead to unnecessary surgery. So or problems with a patient, with the individual not being able to go back to play in a timely manner. But if we follow this farther up here, we can see near the anterior labrum is smoother. This is that superior insertion of the inferior glenohumeral ligament. That's the middle glenohumeral ligament there. And here we can see it fusing here. So this is a superior insertion of the inferior glenohumeral ligament, which is relatively common and is a commonly misinterpreted as a labral tear. But again, the plane of that tear, a tear of the labrum in this plane is virtually unheard of. Labral tears occur in this plane because of the mechanism that we'll talk about later. So when you see the tear in a plane that doesn't make sense, then you have to be concerned about anatomic variants. And if we go to the sagittal images, this can be very seen. I think the sagittal images are very helpful here. This is the middle glenohumeral ligament coming down. We've talked about this. This is that superior insertion of the inferior glenohumeral ligament coming down here. And you can actually see it very nicely in the sagittal plane, which helps confirm it. So he went back with a normal variant and did well. So, yes,
John?
Yes.
There also, I don't know whether you will get into it, but I think you will. There are two parts to the inferior glenohumeral ligaments. It's quite fanned out, and there's a inferior posterior portion and an inferior anterior portion of the inferior glenohumeral ligament were attached to the glenoid. So and that can really vary.
Yes.
And I like to think of the glenoid attachments as origins, and then the humeral attachments as insertions.
Okay.
That's and insertions. I guess when you do MRIs, you try to trace the origin to the insertion if possible.
Yeah.
And then the capsule, as I mentioned, is very thin. You usually don't see it unless it's a ligament. So anything that looks wide and dark is not the capsule. It's got to be something else.
Good. Thank you. Okay. So labral tears, we'll talk about some technical aspects. We've already talked about some anatomic variants. Now let's talk about the tear types. This is an old one. This is a typical tear. This is an arthrogram from the early days, and this was from film, and that's why we see all the streaks here. And here we can see the typical tear. This is in a different plane than the normal variant that we saw before. This is typically due, anterior tears here are typically due to an anterior dislocation of the humerus. The humerus comes over, scrapes against the anterior edge of the glenoid, and tears off the labrum as a shearing injury. And with that, as you know, you can also get fractures of the anterior inferior glenoid, which we'll talk about, and impaction injuries back here. So if you have an anterior dislocation, it dislocates, then you get a firing of the muscles to try to, which is compensatory, and that can bang the posterior superior aspect of the glenoid against the anterior inferior aspect of the humerus, against the anterior inferior aspect of the glenoid, and producing the typical impaction fractures that you're all familiar with. Now, as far as looking at these, sometimes the anterior labrum can be difficult to evaluate. And one thing that was a view that was popularized by a former fellow of mine, Philip Tierman, was the Aber view, where you actually put the arm up over the head in the abducted externally rotated position, the thought being that this puts a tension on the inferior glenohumeral ligament that attaches to the labrum, and then can pull the labrum off, and you can see the tear better. And so in this case, we don't really see an anterior labral tear in the typical position, but in the Aber view, we can see the tear. There's poor signal to noise in the Aber view because they had to use a different coil when you reposition the patient. In actuality, in my experience, it doesn't help that much with the anterior labral tears, though I've got several examples where it did help. But I do find it's very helpful in the young athletes in evaluating the posterior superior aspect of the joint, which we'll talk about. So here's shoulder pain, rule out labral tear. Let's see, who did the last one? I've forgotten here. I think Max did. Jeff, what do you think of this case?
Okay.
Jeff?
Oh, sorry, yeah, I think Jeff got the last one. I can take this one.
Oh, okay. Okay, go ahead then, Jonah.
Yeah, so mind. So anyway, this is rule out labral tear. And we see this kind of irregular signal abnormality kind of anteriorly there through the labrum. It's not really displaced per se. It looks irregular, so
we have some signal there. And then what's this one show?
Oh yeah, then we've got our Aber view, and I guess we kind of displace that and make it more apparent.
Yeah, so this is a case where in the Aber view it does what it was designed to do. We can see that it's lifted the anterior labrum off, and we can see the detachment of the anterior labrum from the glenoid here. So this is a labral tear. Now, what is this structure?
So that should be just ligament pulling.
Yeah, this is the periosteal attachment of the labrum, and it should be paper thin. When it's thickened like this, it means that there's chronic injury to it, and it's had time to hypertrophy, and that only takes about 3 to 4 weeks actually to get thickened periosteal attachment, which we see here. So this is an anterior labral tear, but the periosteal attachment is thickened and intact.
Jonah, what does Aber stand for?
Let's see. Abduction, external rotation.
Absolutely. You also use that Aber in the hip. We'll get to that later. Sure.
I just had a question about the prior case. The next image, the Abre view. Is there also a tear of the superior labrum?
In this particular view, we don't. I'm sure most of. Well, I don't know. We'd have to look at the coronal images to see. And typically, if the patient has shoulder instability with anterior dislocation, the tears don't always go up and involve the superior labrum, but we'd need another view to see it. What you can see here is that there's a lot of irregularity of the posterior capsule back here, and we'll talk about that in overhead athletes.
John?
Yes.
If you look at the head of the humerus, there is an irregularity, and that's probably from the
from a Hill-Sacral.
Chronic dislocations. I don't know whether I'm right or not.
Yeah, probably so. Because you'll get anterior dislocation, then as I said, the muscles tend to fire, it tends to pull the humerus back against the anterior glenoid, and that can produce a wedge-type fracture back here that you're all familiar with in the posterior aspect of the greater tuberosity called a Hill-Sachs impaction fracture.
Yeah.
We'll see more of those.
Some people call this active shoulder motion when there's force applied, the resistance by the ligaments and so on, and the labrum is a shock block mechanism. So what happens is that there's more give to the shoulder. It's not locked like a door with a lock on it, but it gives and then goes back together again. And if it gives too much, of course, that's what you get, either a subluxation or a dislocation. So that's when the shock block mechanism fails.
Okay. Okay.
So we have axial T1 and axial PD fat set. Yeah. So looking at the subscapulars, there's increased signal intensity and maybe some partial thickness tearing at the articular surface. And then the anterior labrum, there's a little bit of signal intensity undermining it, but it's not displaced. And then on the Abre view, the anterior labrum, it doesn't have a normal low signal intensity, but it doesn't displace either.
By that surgery, this was a labral tear.
Okay.
So the Abre view doesn't always work. This was a labral tear surgery. Now I think we should go and talk about different kinds of labral tears, but this is a good place to stop. So why don't we stop here, and we'll pick up the different types of labral tears tomorrow. Okay. Any further questions?
Thank you.
Yep. Okay.
Thanks. If I so